to the Sanjeevani family in India and the world over. I would like to welcome Professor Massimo Caputo and Dr. Giovanni to this webinar. I have got this great pleasure and privilege of introducing these two gentlemen, which are a great example of symbiosis between medicine and engineering. Dr. Giovanni is a senior lecturer in biomedical engineering in University of Bristol, and he has a special interest in imaging and 3D printing. Professor Caputo is a great friend and one of the few professors in pediatric cardiac surgery in the UK. I know only 3 pediatric cardiac surgical professors, of whom he is one. He is a very gifted surgeon and a very keen researcher. There are not many surgeons in the world who have got 150 publications to their name. He also holds the chair of the British Heart Foundation, which is the apex body for fundamental research, which is carried out in the UK and the world over. More importantly, this man is a wonderful colleague and a great friend. This person is a naturally modest individual who does not wear his accolades on his breastplate. He's a very generous colleague, a pleasant man, easy to work with, and I am very fortunate to have been his colleague in the past and continue to be his friend forever. To Massimo and Giovanni, I would like to say, grazie per aver dedicato il tuo tempo e per averci arricchito con le tue consonanze. Grazie mille, Massimo. With this introduction, I will hand over the stage to Dr. Giovanni to carry on with the proceedings. Thank you and welcome to Sanjeevani and to India. Thank you.
Thank you very much. Grazie. Thank you for a very nice introduction. And it's an honor to be, with you, not in person, sadly, but at least, like this, and share some of the research that we're doing in Bristol. So my name is Giovanni. I work with Massimo in Bristol. I'm a biomedical engineer, and I will tell you a little bit about some of the aspects of what our team is researching in pediatric and also adult congenital cardiac surgery, and some of the interactions that we have between different disciplines. So I will start sharing my screen, and hopefully you will see the presentation starting. So today we're talking about tissue engineering, imaging, and 3D printing in congenital heart disease, which are some of the main topics of our research in Massimo's team at the University of Bristol and the Bristol Heart Institute, mainly funded by the British Heart Foundation and other funders as well. So this is part of a research program. CHD and the patients are at the center, and Massimo, myself, and our team are exploring different technologies and different tools to some extent to advance our knowledge and advance the treatment of congenital heart disease. So I will talk mostly about the imaging side and 3D printing, which in a sense stems from imaging. And Massimo will tell you more about the clinical research that we're doing, the clinical practice, the tissue engineering research, and some of the trials that have been done and are being done in Bristol. So with regards to the imaging, we use imaging data in congenital and adult congenital patients to better understand their pathophysiology. And we can conduct, starting from routinely acquired images from MRI or CT mostly, but also echocardiography, both retrospective and prospective studies. We're also working on building imaging data sets along the lines of building almost these repositories of big data, because images are a huge source of data. They allow us to carry out different analysis, and also they allow us to use technology such as 3D printing. They also allow us to apply different analytical methods. So we'll give you very, very quick examples, just an overview, but of techniques such as statistical shape modeling, so to characterize morphological changes in congenital patients, to study hemodynamics, which we can image in vivo and also model in the computer, to evaluate complex indices such as ventricular arterial coupling, which with imaging we can do non-invasively rather than, for instance, conductance catheter measurements, and how also we can integrate all these different informations from different imaging modalities, but also between imaging and biological data. These are just quick examples, but to give you a flavor of the research that we do. This is part of a statistical shape modeling framework. By this, I mean to use mathematical techniques to model the shape of the heart or blood vessels. And here we applied in a study to the aortic arch of patients that have a bicuspid aortic valve. And we can start modeling and tease out both qualitatively but also quantitatively different deformations that are characteristics of these patients and deformations that are characteristic to subgroups. So we can start asking questions, for example, of what is the effect of the concomitant presence of aortic coarctations in patients that have a bicuspid valve, and does it influence the progression of aortic dilatation? And we're using this technique in different scenarios, but this is just to give you a flavor. Not only we can look at the shape of, in this case, the aortic arch, but we can extract quantitative information from the analysis, so we can quantitatively say whether the shape between two patients or two subgroups in a population are actually statistically different. But more interestingly, probably, we can also extract these quantities and correlate with clinical parameters, such as functional parameters and even outcomes. So we can begin and say whether a certain morphological feature may be associated with, for example, a drop in ejection fraction. We can also, as I said, look at hemodynamics, and this we can do in vivo using 4D MRI, so 4D flow that many of you may have heard. This is an example of pulmonary 4D flow in the main pulmonary artery and LPA and RPA bifurcation. 4D flow is very useful because we get three-dimensional information as well as quantitative information about differences in velocity in a certain district of the circulation of interest. So on the right-hand side, you have examples where we can compare flow patterns, let's say, in healthy volunteers and in patients with bicuspid aortic valve to link with the previous example. And we can also process the data to extract, again, quantities such as wall shear stress, but also kinetic energy measurements that tell us more about not just how the blood is flowing, but what is happening hemodynamically, but also energetically. So we can start unpacking differences between different scenarios. And this is part of the work that mostly one of our PhD students, Frozo, is doing in Bristol. As I said, we can just not only look at the images and perform this analysis, but we're trying to begin and link modeling and imaging data with biological information. This can be proteomics data, this can be, like in this example, histology data, but effectively through the work that Massimo and the surgeons are doing, we're able to collect biopsies in patients, store them and analyze them, but design studies prospectively whereby these patients before their surgeries have been imaged, for example, with MRI, including 4D flow, and then we can start looking within the same patient at possible correlations between hemodynamic changes and changes in the wall properties at the level of whether it's microRNA or protein expression or differences in the histology. And we find this line of research really exciting. We also can look at links between the morphology and not just the flow, but also the function. This is an example from another PhD student of mine that did actually model the carotid artery, but we can apply the same framework to different parts of the circulation. So here the idea is again to use statistical shape modeling and model a blood vessel, changes in the morphology, and extract quantities that we can use, in this case, to correlate with wave intensity analysis. So as part of our imaging research, we have a framework whereby we can extract wave intensity analysis from MRI data. wave intensity being a hemodynamic index that tells us about the working function of the heart in relation to the remainder of the vasculature. So in effect, this can be a non-invasive indicator of ventricular arterial coupling. And as you can see in the bottom right panel, it can also tell us about the aortic or any blood vessel, in fact, Wien-Kessel or reservoir properties. So also we're looking at what's happening in diastole, and we can decompose the information of pressure and flow with these mathematical techniques, but then we can link to what's happening also at a morphological level based on imaging data. And finally, we're looking at this in many scenarios that are relevant for CHD patients, one of which, for instance, is pregnancy. So we had a fellow that worked in our team and is currently working in the ACHD team that is particularly interested in applying these techniques such as imaging data, strain analysis from MRI, but also MRI-derived wave intensity analysis to conotruncal anomalies, which is a study that we've done, and particularly a bigger study of tetralogy of Fallot, looking at patients before and after pregnancy, and start using these imaging techniques that look at the function and the size and the shape of the ventricles, left and right, obviously, to see if we can learn a bit more about ventricular remodeling, tetralogy of Fallot, and other truncal anomalies, particularly in the scenario of pregnancy. As I said, imaging is also important to allow us to do a whole body of research around 3D printing. 3D printing effectively is a technology which revolutionized the field of manufacturing across industries, including medicine. And in medicine, it is based on the availability of 3D imaging data sets, which, of course, we can acquire routinely in CHD patients. So what we've done with Massimo and the team in Bristol is to establish a lab with our charity of the Children's Hospital, who's generously supporting it. So we created a 3D printing lab in the imaging center where we acquire the research images. And that allows us to have an in-house facility and do a lot of 3D printing in-house, both for providing models, in other words, a different way of looking at the images that we can hold and look third-dimensionally to our clinicians, but also to conduct a lot of research studies. So 3D printing is very versatile. I'm sure you are familiar with the technique, but in CHD, I think it's particularly interesting. And a lot of my research has looked at the many applications that are, of course, looking at decision-making and informing surgical practice, but it actually include a lot more. So we can use 3D models for training medical staff, training students, performing a research study with experimental setups, as well as counseling patients and communication studies, which personally I find extremely interesting and relevant. So we have a workflow in-house, as I said, to build models. We also have collaborations with industrial partners such as Materialize. And we work with other centers, and we are one of the 3 European centers as part of the 3D Plus special interest group within the Society of Cardiovascular Magnetic Resonance, which essentially is looking at centers like ours to define protocols and best practices in using 3D printing in cardiology in general, and for us, of course, particularly in CHD. So this is just a schematic of the setup that we have. We have desktop 3D printers, we have access to imaging facilities, and we can produce models for both our pediatric and adult patients, supported by the Bristol Children's Hospital charity and appeal. We can produce, and we have produced hundreds now of clinical models. Here are just a couple of examples to give you a flavor with the images, the 3D model and the 3D printed model, in examples of cases of coronary anomalies like this one, or subaortic stenosis, or truncus arteriosus, and I could give you many. These are just to give you a flavor of what the models look like, and the workflow is very standard. So we process the images with our 3D software, import in another piece of software to convert the images into the format that is suitable for printing, and then print in-house. So we do all the steps of model generation and cleaning in-house in our lab, and then provide the models to the clinical teams or to a surgeon like Massimo to view the anatomy in a different way. So it's complementary to the images to the data that we have in the images. But as I said, and this is actually a good example, the model that it's on the screen, the model can also be used by a surgeon to talk to a patient and their family. This specific example that is on the screen is a patient that had multiple operations as part of their repair of truncus arteriosus. And before the previous surgery, a couple of years ago, Massimo could actually use the model to show the position of the pulmonary arteries, to show a narrowing on the conduit that needed to be addressed. And so the model was actually useful for the parents to understand the need for yet another operation as part of the surgical pathway of this patient. And I'm very interested in evaluating, particularly with a psychologist at Great Ormond Hospital, Dr. Jaray, who's a close collaborator of mine, evaluating how these communicative processes work actually with the models. As I said, we can also do research studies. So this is an example of a case series of different coronary anomalies that one of our students produced based on CT data. And here's another example of research that we're doing. So we're very interested as a team into the technique known as Ozaki procedure, or Ozaki repair, to repair the aortic valve. And what we've done based again on CT data is to generate flexible aortic models that the surgeons can use to size the sinuses of the aortic root before the Ozaki repair. And the idea underlying this is that in theory, the surgeon then can, prior to the procedure and thus saving time, pre-size the leaflets that can be cut and then sutured during the Ozaki repair. So here's an example of something that comes from a very specific surgical technique that Massimo as a surgeon is interested in developing clinically, but also studying at the research level. And then just again to give you a flavor of all the research that we're doing, this is in collaboration with the University of Verona in Italy. We've done a study of fetal models based on microfocus CT. This is post-mortem data, but we're also interested in Bristol to explore in vivo fetal scan, how to use, in this case, echocardiography data to make models like this that can be used either to study a range of congenital anomalies. So this was a study that included several, from single ventricles to truncus to fallow, but also potentially models in pregnancies that can be used again for very delicate and important communicative purposes. And here's just again an example of the micro CT data, models that obviously are so tiny, but with the ability of the printer, we can very easily scale them up if we want to study the anatomy in detail and print, in this case, just as an example, at a 5-fold magnification. I will not go into detail about 3D bioprinting because it's not exactly my field of research, but it's part of what our team is also interested in because the principles are the same as 3D printing. The 3D bioprinting relates more to this process of printing layer by layer, like 3D printing, but in this case, laying down cells with the goal of creating viable implants that could be used in patients. And this is something that Massimo will mention more as part of the tissue engineering research that our team is pursuing very actively. So just to conclude, in keeping it within 15 or to 20 minutes, these are two of the elements of what our team is researching. And something that I want to mention is that we also have an ethos of patient and public involvement that kind of underpins the research that we do. By that, we mean that we're very keen to hear from patients and involve patients in our research. And we do this in many different ways, regardless of the specifics of the research. So we have done many workshops and we've worked creatively, not just with the models, which are a fantastic tool to involve the public, but for instance, I have a close collaboration with an artist in the UK whose name is Sophie Layton, who's very interested in working in a medical landscape. And so we've run workshops both with patients and with clinicians and exploring what is the narrative dimension of something like congenital heart disease, including different scenarios from transplant to the siblings' experiences. It's obviously a very, very complex and multifaceted and also beautiful landscape in which we can use some of our tools like imaging. You can see here echocardiographic data that is shown in a workshop, but complemented with artistic practices. And so just in a final minute, I will show some images from one of the videos, and I can tell you more in the Q&A if you're interested, of how we can extend these things and complement it with our research. So we did a big piece of work that was a national project with multiple exhibitions in big museums around the UK, using things like MRI. You just saw a digital animation inspired by MRI models, but also original artworks that were created starting from the stories of patients that have congenital heart disease and their families, to explore both the metaphorical and the medical side of what it means to have congenital heart disease. And this was a big project that we carried out in 2018, and now we're still evaluating and developing more studies along these lines to extend this kind of participatory work and look at patient experience. So I hope that gave you a flavor of some of the research that we do. I will pass obviously now to Massimo, that will talk to you about the more clinical side of the research. And I just want to acknowledge obviously all the people in our team and also the collaborators in Bristol and in other centers, because all of this research is very collaborative. Thank you very much.
Thank you very much, Giovanni. I think I will take over now, if I can maybe share the screen now. I think I need to be given permission. Yes, there we are. So really a great pleasure to be here, and thank you, Ragini, for your introduction. It was really too generous. I have to say I have had a lot of chat with Ragini about this Sanjeevani Center. She's now really putting all her effort into, and we are very, very jealous, because I can only say, Ragini, we have lots of children you operated on, and when they come back to us and say, no, I want Dr. Ragini back, I don't want to be operated by you. So this is just a testimony of how much we miss you here in UK. This talk is more now, after Giovanni's talk, is more about the clinical side of how we can use tissue engineering to really trying to improve patients' outcomes in congenital heart disease. Now, we know that patient outcomes is quite good. This is data from the UK. We tend to have a registry when we analyze all our survival. And here, as you can see, over the years, the survival, the mortality is going down really to very acceptable levels, and in fact, fantastic, I would say, levels of survival. So we all feel, and this is all over the world, that survival in congenital disease is not really, it is still an issue for some high-risk operation, but not for the majority of our children. Oops. Yes, and this is the data, for example, for arterial switch operation we have collected over the years. Again, you have very excellent early outcomes. So the problem, one of the major problems is this, that as you know, the survival is increasing over the years, and now there are more adult patients coming across. As you can see from this line, this is an old publication until 2000. This line, which is the adult patient with congenital disease, is now higher than the pediatric population. These are two of our pediatric patients who are now having children themselves. So this is creating a new, really, chapter in congenital heart disease, pregnant patients with congenital disease having children themselves. So really a new type of area of research. Now, this is an example of how important tissue engineering could be This is a patient with truncus arteriosus. Callum has been one of our champions, helping us to raise funding. And at the end of the operation, you do use this conduit which connects the ventricle to the pulmonary artery. This is specifically is a called contigra conduit. And even at this age, a neonate looks huge, but this conduit will not grow, will calcify over the years. And this patient has already had 2 reoperations and coming for the 3rd quite soon. We know current materials don't work very well. We can use synthetic material, we can use natural material, and they all have limitations. As we all know, as surgeons, we are faced with this wave of patients coming back from reoperations. Homografts definitely are a very nice material to work with, and we've doing some work, and this is work done, a publication from South America. We're doing some work with decellularized homograft, but even in those, you can see after a few years, there is still calcification. So even homografts, which are perceived to be probably the best tissue we have at the moment for valve replacement, they are still prone to failure and calcification. This is a series we published recently where we analyze all our long-term outcomes with pulmonary homograft versus bioprosthesis for pulmonary valve replacement in tetralogy of Fallot. And basically, to cut a long story short, we found that homograft performed better than bioprosthesis, had a better long-term longevity, and also better gradients across the valve at the follow-up. From this study, we concluded that, especially in this age group, 10 to 20 years of age, homografts probably are better than bioprosthesis. And this is, in a way, quite important because we know that bioprostheses are used very often for tetralogy of Fallot pulmonary valve replacement. It's a quite easy operation. It's a redo operation, but it's a standard operation. And this is a meta-analysis showing that the perioperative outcomes for this operation are really excellent. Nevertheless, we know that the valves fail after 8, 9, 10 years. There is a huge decrease in event-free survival for these patients, and most of these will come to reoperation. This is a specific valve called perimount, which is probably the most used biological valve, and this is a case series from Boston where they show that the younger you are, here in this line, the higher the percentage of reoperation and failure of valves in the pulmonary position. What about TAVI? This is all about, percutaneous valve, but we also know that these valves, they are subjected to problems in terms of degeneration and infection. I did reoperate recently on an infective TAVI valve, a Melody, and it is really a nasty valve, a nasty piece of work to have to undergo with especially with infective endocarditis. So even the minimal invasive approach are not ideal. This is a very interesting study from New Delhi, in fact, where they use autologous material, autologous pericardium to create a conduit valve with a 3-leafless valve. It is a very interesting idea. But the only problem with this is that one of the issues sometimes is that we don't have native pericardium. Most of these cases are redos. So there is also a limitation in the amount of pericardium you can use. And also there is an issue whether you treat the pericardium with glutaraldehyde or not, because we know from the other experience that in long term, glutaraldehyde can be quite aggressive in creating tissue damage. So we have chosen a pathway by which you can collect patients' cells during the perioperative period, and we are quite lucky because we can make fetal diagnosis and we can either harvest fetal stem cells or umbilical cord stem cells, and then seed the patch and the material that we want to use for surgery with the patient's own cells. As I said, prenatal diagnosis is quite common. We have what we call the gifts from the parents, is the umbilical cord, the placenta, which is full of cells and material that we can use to create patches. From this perinatal material, we harvest the mesenchymal stem cells, and then we can seed the material in a bioreactor, as you can see here, and create a patch, a valve, or a conduit according to the procedure you want to do. And this is a nice large animal study that we did in Bristol, where we replaced the left pulmonary artery of a very small animal, around 10, 15 kilos, and then we let the animal grow. And what we saw that if we replace the left pulmonary artery with the seeded tissue engineered graft, there was a much better growth of the cellularized graft compared to the acellularizing, proving the concept that stem cell tissue engineered grafts can grow and have a very nice biological layers, which is very similar to the native pulmonary artery, and as you can see in these pictures, compared to the acellular grafts. And this is a 3D picture of cells seeded on the graft, and this is one of the products that we're using, is a cellularized core matrix, which is taken from animal intestine, is a decellularized material, and we seed it with the patient's own cells. And then we use the amnio, as you can see, amnio membrane from the placenta to create the leaflet. Then we create a conduit, and then we implant it in the large animal model. This is the 3 leaflets valve of amnio membrane seeded into the core matrix graft. And this is a follow-up, and again, from some of the animals we've done, that the seeded grafts have better growth. Here is very small, but from 1.1 increase to 2.1, the group with seeded cells compared to the control one, where there was no growth. And when we also look at the histology at postmortem, again, the seeded graft shows very nice endothelialization and really favorable histology after 6 months. Now, you have to understand, after 6 months, an animal from 10, 15 kilos grows up to 100, 120 kilos. So this model is very good to test the growth potential of these products. Then I had a very good collaboration in Italy. This is Palermo in Sicily. I'm just doing this as almost like a tourist information to Sicily. Is a fantastic place. This is the food that we have been eating together with this team. And this is the engineer lab we've been working. In this lab, we have incredible equipment. This is an in vitro heart, which can mimic exactly the pressures and the function of the valves. This is a laser machine which can cut any material you want. This is a bioprinter, and this is the laser which can create the shape of the valve that you want to use. But interestingly, this is a stitching machine. As you can see here, we create a model of 3 leaflet valve, which in this case is just a test with the ducting tissue. And then you have the patch with the leaflet stitches into it. And then this is the other model. This is the test of the valve in the pulse duplicator. You can see the valve opening and closing. And this is the valve with the leaflets created with amnio material. And with creating the same hemodynamics that you will have in vivo. Let's see. So these are the leaflets stitched with the equipment that I show you. So this is exactly the way to go for when creating this kind of valve in a lab and test them in vivo. As you can see here, this is the pressure created in the equipment to test the valve at the pulmonary pressure. So next step is to go through the regulators in UK, which, as you might expect, are quite tight, and then to have a safety 5 patients born with tetralogy of Fallot to test this product. During COVID, we have slowed down, but I just want to tell you a story of this small baby called Finlay, who underwent an arterial switch operation with the intramural coronary arteries. The operation was complicated by heart failure with severe damage to the heart because of coronary occlusion, and he went on ECMO, and he had a very terrible left ventricle, as you can see here. So there was no heart transplant option during COVID. So we decided to try and test these our allogenic mesenchymal stem cells, which we produce at Royal Free London in one of the really best GMP facilities we have in Europe. On compassionate base, we did this injection of the allogenic mesenchymal stem cells. These are the same cells we're using for tissue engineering. And we had really incredible results. We didn't expect this. The baby was weaned from intensive care, from all the anotropic drugs, and you can see it's really growing. And this was an unexpected results, really, in somebody we were not expecting to survive. So we have direct evidence that cell therapy is important, can work, and in the right type of environment can have also excellent results. When we talk about leaflets, is obviously very complex to create valve leaflets which are which can last long. And this is another example of tissue engineering we are working on. We are not using cell at this stage, but we are using microRNA, which are small particles that can travel and can use, and they are like messengers for inhibiting valvular calcification. So with the transviral approach, we inject this microRNA in these nanoparticles. Then we seed the nanoparticles into the biological tissue, which is going to be the leaflet. And then we have a leaflet with which has a biomarkers inside, which work as an anti-calcific treatment. And these are just pictures showing all these material inside the leaflets, and the cells they can attract when then the cells are seeded. They can after that implant in the scaffolding and make the scaffolding as a live tissue. And Giovanni mentioned about the Osaki procedure. This could be a very good tissue engineer strategy for the Osaki procedure. You're probably aware that Dr. Osaki in Japan has developed this technique at the moment using autologous pericardium. This is just the way the technique works. You harvest a patch of autologous pericardium, and then you literally, by shaping with the correct sizer, 3 leaflets into the annulus. As you can see here, this is you start with the right coronary annulus, then you attach the annulus to the commissure at the back, and really this is for the surgeons in the audience. And then you have this very large coaptation, which you think is never going to work, but actually it is this large coaptation that prevents the regurgitation. This is a very nice example in a 15-year-old boy with severe aortic valve disease, in fact due to rheumatic fever. We are using this technique more and more. We're using this in young children, but also mainly in young adults. There are series from Boston, from Great Ormond Street, pushing the boundaries, trying to use this even in the 5, 6, 7 years old. I've done a couple of cases in this age group. My overall series is around 50 patients, mainly above 18 years of age. And when you don't have to do a cono, so when you don't have to enlarge the annulus in a child, this is probably a good alternative to the Ross cono operation, which is still the gold standard for the infant children with aortic valve disease. There are other techniques which are important to mention. The hybrid technology is also coming up. Is basically a joint effort between cardiologists and surgeons. I spent 2 years in Chicago working with Damian Kenny, a fantastic cardiologist colleague, and we have developed this technique by which we do a pulmonary artery plication in younger adults with tetralogy of Fallot, and then we insert a melody within an RVOT, which otherwise you couldn't have done this minimally invasive because it was too large. So we have now a program of hybrid technology in Bristol where we treat pulmonary valve replacement hybridly with ventricular septal deflect, and I will also touch base on Marfan syndrome. This is our first series from Chicago. We're now much larger series. And what we found is that there is a benefits in hybrid technique in terms of length of stay of these patients, and specifically the use of blood products, less blood products used, because you don't have to go on bypass, you don't have to stop the heart, you don't have to cut inside the heart. There are some high-risk patients you can use this technique. This was a patient with severe RV failure, end-stage RV failure. We had a joint discussion, and we treat this patient with a RV plication, as you can see here, and then insertion of the sapien valve with a much smaller, as you can see, RVOT here. And this is another example of a patient, a 50-year-old with pulmonary valvotomy. There was an attempt to do a transvenous pulmonary valve replacement, which failed several times. So with a very small subxiphone incision, we inserted a melody valve in this case. Finally, I would like to talk about the peers. The patient with Marfan syndrome, we know the classical operation is a valve sparing route, but with the 3D technology, we now can create what we call a personalized external aortic root support. So from the CT scan, we create this support, which is a mesh, and the operation is done off pump. It's always, you can go on pump. You can see here you go around the right coronary artery because you really need to go down the aortic root to wrap the aortic root with this material. And this is going around the left main. This is not an easy thing to do, but with a bit of patience, you can really go very deep down into the left main, you can see here, and then going down into the ventricular aortic junction, where you need to then implant the graft. I just show this running. As you can see here, we harvest quite a long way down the aortic root. This is the right coronary artery we've been around, and you can see how deep we have to dig to reach the ventricular aortic junction. Now, from there, this is the material that we use. It comes in a support here. We have the coronary artery already marked, so we know exactly where to create these little flaps that need to go around the root of the aorta. And this is very important because you really need to go down. And this is the ventricular aortic junction here. You really need to go down all the way down to that level. And finally, this is the end product. The whole aorta is surrounded by this personalized exostent. Now, we have done more and more cases in the UK, and more centers are applying this technique. This is an old slides with around less than 200 patients, but I think now, up to now, there are around 300 patients in the registry. And this is the age distribution. These are the pathologies. It can be applied also for patients who had a Ross procedure with dilatation of the root or transposition of great arteries, but mainly in Marfan syndrome in patients with connective tissue disorder. This is a 10-year follow-up with no growth after this exostent, and this is just showing the number of patients growing over the years and the number of centers. Now, you need to be careful because going around the coronary arteries can create problems. There have been 1 or 2 reports of perioperative damage of the coronary arteries with perioperative MI, and out of 200 patients, there was 1 perioperative death and 1 at follow-up. And even in this technology, you could develop tissue engineering. This is another study we are participating where we inject parasites into the aorta of an animal, and we use glue to inject the parasites. And you can see here this histology, again, the cells incorporating very well in the aortic wall. So even for connective tissue disorder, tissue engineer has got a great potential. So I want to end this talk by saying a tissue engineer will develop better biocompatible matrix for valve substitute. Cell-based molecular and drug engineer for scaffolding is very promising, and the bioreactors also development is something we need to keep an eye. In terms of congenital heart disease, I want to just finish with this slide showing that it is a team effort, as you know. These days with coronavirus, the research has taken a little bit of a slowing down in terms of animal work and lab work. And there is a lot of work going on, the big data in congenital heart disease. In the UK, we are quite lucky that we have a lots of registry covered by the NHS, and our next effort is to create a link between this registry in the UK, but also internationally. And all these aspects of research can be a possible collaboration between units. Thank you very much.
Thank you, Massimo, and thank you, Giovanni, for wonderful talks. We'll open the floor for questions now. We'll keep giving them to you as they come along. Thank you.
Thank you. I'll probably stop sharing, I suppose. Yes.
So while we are waiting, Massimo, just a couple. Okay. There is one question, yes, from one of my colleagues. He's a surgeon who works with me, Dr. Vishal. He's going to ask you something, Massimo.
Good evening, sir. My name is Dr. Vishal Agrawal. I'm a pediatric cardiac surgeon here in Raipur with Dr. Agni. Just as you elaborated about the tissue engineered developed valve, how much time do you think in the future we will be able to see it practically applicable in the child on table?
Yes, that's exactly the point. We are about to apply for permission for a safety trial to the MHRA, which is like the FDA in UK, basically. So we're hoping that with this specific product, which is basically using mesenchymal stem cells as the cell therapy, seeded on the core matrix, which is the one of the tissue we have used because it's a very nice tissue to accommodate and seed cells. And on top of that, we create a leaflet made of amnio, which is the membrane surrounding the placenta. So we're going to test this in 5 patients as a safety trial first. And that's the regulation in the UK. You need to do a safety trial in few patients to make sure there's no reaction and so on, and then doing a proper study. So I'm hoping for this specific product to start in a year time. We have been slowed down by COVID, but the proof of concept is there. We have all the animal proof of concept, safety and efficacy. And also, as I show you, we have done one a patient testing the allogenic mesenchymal stem cells with no side effects. In fact, with the recovery of this poor baby's heart. So I'm hoping that this case can also help us in pushing these. There are trials in the States done with autologous mesenchymal stem cells in patients with Norwood, undergoing Norwood. So our challenge is to push this with allogenic, so not the autologous one, because it's much more practical to have allogenic, which are produced from the placenta, from the cord tissue in these GMP facilities. And then when you have a patient, it's much more practical to do all the tissue engineering, which is 3 weeks work, really 2-3 weeks work in this unit, and then have the product ready. And we have shown that allogenic also are not, they don't have side effects, don't promote immunoreaction to these patients.
Thank you, sir. Professor, can I ask one more question? Just out of fantasy. Is anytime in the future, a whole heart can be generated from the stem cell?
Sorry, say again?
Just out of fantasy, I'm asking, down the future, whether the whole heart can be generated from the stem cell, impregnated on a scaffold with the help of a 3D printer.
Yes, that's everybody's dream, isn't it? There was that famous Nature publication where they recreated a beating chamber in a rat using pluripotent stem cells. We in Bristol have a very an excellent lecturer. She worked in Stanford for many years. She's now in Bristol doing work, chimeric work. So what chimeric work is, they take the egg from an animal, and then they implant interspecies type of material. So then, in theory, I don't think that the whole heart is going to be in the near future, but I'm hoping that with the chimeric work and also using pluripotent stem cell, we could create pieces of the heart, such as an RVOT or an apparatus, or let's say an aortic apparatus. Not quite the whole organ, but I truly believe that that's achievable in the next 10 years.
Thank you, Professor. Thanks a lot.
There is a question from rather Josh, I think, to everyone about microRNA in congenital heart disease. And I think, yes, this is a very important part of congenital heart disease. MicroRNA are becoming more and more important in this field. I gave an example of one of the study we are doing. So we inglobate specific microRNA, which is known to reduce calcification, into a nanoparticles, then can be incorporated in the leaflet, and possibly this could be so innovative for reducing long-term calcification of the material.
And Massimo, if I can add, something else that we're doing in Bristol is also the biomarking work with microRNAs. So we have an article, for example, about microRNA 1 in congenital heart disease patients and correlations between that and postoperative complications. So with microRNAs, there's also this interesting angle about biomarking.
Professor Massimo and Dr. Giovanni, thank you very much for the very inspiring talk. I think it's been very revealing in terms of the research and the cutting-edge technologies that you are using in this field. One very, very basic thing that we are missing is a registry. We do not have a national registry of congenital heart disease in India. And, Professor Massimo, I heard you mentioning that briefly in your talk. This is not a question, but more in terms. Sanjeevani has taken upon himself to build one. Potentially start with this state that we are in here, and then make it for the entire nation, a national registry. I'll probably get in touch with you offline to get more details on how to get that started, how to get this work going. We have started talks with the local university here, and we're looking for some guidance in this space. So
Absolutely, this is vital. We talk about this with Ragini a lot about having, and she knows all the details about large database, big data. Having spent a large part of her career in UK, she knows exactly what we are talking about. And I think we are really keen to establish a collaboration with you guys because apart from obviously the friendship I have with Ragini, but centers in India are now leading in terms of volume and quality and the quantity of work that you do. So you have such an incredible resource there to lead not just the clinical but the research in congenital disease. I truly believe that much higher than the UK. Trust me, you are in an extremely advantageous position if you can utilize that.
Sure, Professor. Thank you so much. I look forward to getting in touch with you on that one. And we welcome you and Dr. Giovanni to come to India as soon as I think the commercial flights open up. We're looking forward to your visit here.
That's one of my priorities in life, trust me.
Thank you so
Massimo,
much.
just a couple of questions, Massimo. This little fellow Finlay, you injected allogenic stem cells into the ventricle?
Yes, into the area. Yeah. So basically, he had a intramural left coronary artery, which was complicated postoperatively occluded, and then basically had an important anterior. So we knew the area where to inject, which was basically the LAD territory, and we injected 6 million cells in 4 different locations.
4 different. And in how many days did you see improvement, Massimo? How many days did it take?
We saw this patient was with us for good 4 to 5 months, you can imagine. But actually, this was before. So after we inject, after 2 weeks, he was extubated. Then we keep him on inotropic support for another 2 weeks, I think. And then gradually, so we were very, very cautious to wean the inotropic support. But, I was personally surprised. It wasn't my patient, but I was involved because of the stem cell project. So the mom, she would say, I'll do anything. There is no transplant option. Can we? And I explained to her, we never done this before. This is absolutely experimental. It's on compassion base, but, we did it. And to be fair, I have to be honest. I don't know if it was really the injection that made the difference, but it's such a coincidence in timing and in improvement of the function after the injection that I have to believe that the theory behind is promote neorevascularization. It is probably true that these cells, they just promoted much more neorevascularization and collaterals that gradually improve that function.
Okay, great. Now, do you think, just a theoretical question, will it make a difference if there is acute ventricular failure as opposed to chronic ventricular failure? Now, this, I presume, was an acute event.
Yes, I think so. I think you're right. It's a great question, and we don't know. We don't know because there are no trials on the use of these cells in an acute scenario in children. There are in adults, when the patient comes with acute MI, PCI, there are trials of injecting cells with mixed results. Some trials show benefits, some others don't. There is a trial on autologous mesenchymal stem cells from the Mayo Clinic with patients undergoing Norwood operation at the time of the Glen, and they used the same type of injection, but they were autologous. And they did show improvements, but this was not on an ischemic base. This was on a single ventricle base.
Yeah, one more question, Massimo. Just one more. The tissue engineered grafts, Massimo, the one you implanted in the animal model, in the LPA, do they develop blood supply?
Yes.
You have shown very beautifully that it grows, So
yes, we show neo vessel inside the conduits. So there is on the outside, on the inside you get endothelial, cells, and you get layers of smooth muscle cells. But on the outside, you get neo vessels clearly shown on the microscopy. And we've done this not only for the LPA, but we've done also an experiment we published in JAC on the RVOT. So we made a cut in the RVOT of a piglet. We used cellularized material versus a cellularized material, and we clearly show that the cellularized material has more vessel production in the patch, and also the MRI, there is a better improvement in the fractional shortening, and in the strain. We measure the strain of that region, which shows benefits if you use a cellularized product. So I really believe that if you can cellularize your material, especially for the RVOT, which we know can create a scar, can create problems in the future, it is an advantage for babies with tetralogy.
Yeah, okay, wonderful. Massimo, I'm just going to ask one of my professors who taught me, Dr. Khande Parkar is here as well. I am just going to ask him if he has any questions for you. Professor Khande Parkar. Hello? Yeah. Or anybody else, if they have a question? I have a question. Can I ask Dr. Giovanni? Giovanni, can I ask you a question, please? Hello?
Yes, of course. Yes.
Hello. Okay. So thank you for a wonderful talk, Giovanni. Couple of questions. What about, so when you are doing 3D printings of the heart, what about the accuracy of the intracardiac anatomy? How do you ascertain that? Because even MRI can have artifacts.
Yes, so what you 3D print depends on what you see in the images. So whatever you see in the images, in a sense, it's as much as you can 3D print. So given the caveat of the limitations of image resolution, whether it's CT or MRI, depending on what it is that you want to measure, there will be that caveat. Having said that, there have been studies that have shown that the technique is highly reproducible. So if you make shapes of known volumes and then 3D print it and measure the volume again with another scan, they showed excellent agreement. So the technique is very accurate to pick up the details that you have. Now, anything that you don't see in the image or that you don't see well will also not be accurate in the 3D print. Yeah, that's a very good point.
Yeah, so the extent of filling will also make a difference? The extent of filling of the chambers will also make a difference?
I think it depends on, I think probably not. I think it depends on what you are particularly wanting to see. So there are, for example, even just simple things such as choosing to reconstruct from CT rather than MRI, which we did when we were doing the coronary study, because obviously the spatial resolution is higher. But filling, I think it depends. I think we were discussing not later than yesterday, in fact, with our team about a study that we did on models of post-infarct VSDs and, how to capture the changes of the VSD between systole and diastole and points like that. So obviously these things are important when present, depending on the purpose of the model. But if the model is to inform to some extent the decision-making process, you want to make sure that you are not showing something that is deceiving. So in that case, I would either show both or be very clear as to what you're looking at, I would say.
Yeah. Okay. Thank you. But then question to both you and Massimo, to be honest with you. So there is a condition called DORV. Massimo? Hello?
Yes,
Massimo.
yes.
So there is always this question in the mind about the rootability of the aorta. And you get fluxumed on table because no amount of imaging can actually tell you whether it's going to happen or no. The relationship of the aortic root to the location of the VSD, and sometimes there are a lot of surprises on table in these kind of patients. So it would be actually my dream to have a 3D model of all kinds of DORV, the fallow type and the TTA type, and maybe to perform a virtual operation on that particular heart, basically to see if it actually works. What are your thoughts on that?
So I'll probably
Massimo and Giovanni, yeah.
I'll pass to Giovanni because he's done fantastic work on this. He's done loads of series of DORV with GOS, and I've been through, I don't know, 20 models, and then see that what he did very cleverly, whether the operation, the operation I proposed on the model was then the operation performed in real life. And also he's done virtual, they have a fantastic equipment at GOS where they do virtual analysis, and that's really game changer. You can actually go inside the heart and cut pieces of heart virtually and look at the VSD in real time. So, I mean, Giovanni, I'm sure, has got more to say about that.
Yeah, no, but I was going to say the same. I was going to say that DORV is absolutely a scenario where increasingly the data is showing that models can be useful. There is also a randomized study, I believe, from 1 year ago that showed that there was some changes in decision-making, particularly in DORVs, when a model was available. The models can be made with cuts to show exactly, to give more insight into baffles and, the kind of decision-making that you are describing. And as Massimo said, also on top of viewing the models, we also can make virtual reality models. So that is something that we specifically tested on a series of DORV cases. So whether, again, we can augment the information that we can give in that specific scenario.
The other thing, Regina, I want to add is that, for example, I've changed a couple of cases. I've changed looking at the model. I've changed the operation. Like there was a truncus, which I saw the model before, and the RPA was, like all around the aorta, and I had to enlarge it, and I knew I was not going to. And I don't normally transect the aorta in pulmonary homografts in truncuses, but this case, I look at the 3D printing and I said, okay, in this one for sure we need to transect the aorta and replace the aorta with a conduit because of the anatomy was challenging.
It seems like a great way to go ahead, Massimo, to have a 3D printed model to know the anatomy from inside and perhaps perform a virtual operation so that, it increases the safety, it increases your confidence of doing something rather than landing into trouble on a cross-clamped heart, actually. So, it's a dream to have this sort of technology.
Yeah, we are using them more and more in a multidisciplinary meeting as well. So we look at the model as well as the imaging, and some decisions have changed because of the model.
Yeah, I'm sure. Massimo, I'm just going to ask the audience if there are any more questions, and I will hand over to Mr. Srinivas, who's our chairman, for some concluding remarks. Just ask the house if there are any questions, please.
Okay, Ragini.
I think they're having some audio trouble. We'll just give it a second.
Ravi, can you hear us? Here from Kargar?
Very feeble, sir. Very feeble.
Okay. Right. Professor Massimo and dear Giovanni, if you can hear all of us, I'd first like to say Amor, Amor, Amor from Sanjeevani. That's what Sanjeevani stands for. This has been a good introduction to us to something I'm personally very keen and passionate about integrating research with clinical work. There could not have been a better beginning that Ragini could have made than to have you and Giovanni initiate this dialogue with us. You are right in your observation first that what has been Bristol's loss is Sanjeevani's gain in the form of Ragini. So we will share her with you as and when the need arises in whichever field of work. Having said that, I do know you're aware that there is enormous opportunity of working together. I do know research is a long road and takes considerable time, but technologies are changing and improving considerably. What existed even 2 years back does not, and there is tremendous improvement now. I do know historically much of research is CT MRI based primarily, but with everything becoming real time in the world today, it does not matter in which part of the world you're sitting. You could be sitting in Bristol, but pretty much doing all that happens in Raipur or in Palwal or in Kargar. That is the beauty of today's technology. What I would want you to do with Ragini primarily and with Sanjeevani is enumerate heads under which you see collaborative opportunities emerge, you know. You did say rightly that a registry is something you could help us in commencing. So what really comprises this registry is something we need to understand in perspective because countries' needs for registries change. They are as much medical and scientific as much as socio-economic and what we in India now have as an Aadhaar or a national citizen identification based registry also. So we must understand the perspective of how we should be creating this registry and how it could connect itself to greater use therefrom. You are more than aware of the large volumes that Sanjeevani is able to throw up. And I, for one, am very, very keen that this should be put to good use. You know, you would be very happy and heartened to know that Sanjeevani is very uniquely positioned in matters of research with patient consent. Now, this is something which comes very forthcomingly and overwhelmingly, I would say specifically in Sanjeevani, because we are a free of cost center and there is tremendous love and empathy in what we do. So every patient feels obligated that some other mother who has a congenital heart child must be helped, or somebody else should be hopefully prevented from having a child with congenital heart disease. So there is a tremendous synergy between preventive healthcare and curative healthcare, tremendous synergy between ground level maternal health and nutrition as well as congenital heart disease. And of course, I did hear from you stem cell possibilities, which is also certainly something that will need to be looked into. So arriving at a working sheet based on the needs that India has and what would be the right thing to do would be the first thing we should first get out. And Ragini, she's also a member of our research board, so she would be able to take you through what projects we are concurrently, which are at a pretty nascent state, which we are engaging in. So all in all, this is a long journey, but then this is a small and a good beginning, and the best thing is there is a good partner in Massimo and Giovanni and team that we have. So my best wishes and congratulations for this commencement. And we wish each other Godspeed in this great service we will be doing for times to come for children being born with congenital heart disease, with better technologies and better ways of addressing this problem. So once again, congratulations, Ragini, and to everybody in Raipur, and all my colleagues in Palwal and here in Kharghar, and everybody watching this program. I know there are many watching this program. And again, amor, 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 Massimo and Giovanni, to you and to your brilliant team. God bless.
Thank you very much.
Thank you very much, and really appreciate the vision of the Sanjeevani Center and the help you're giving to, I would say, millions possibly of children. Really, really well done. It's incredible the work you do.
Thank you very much, Massimo. Thank you, Giovanni. It was a wonderful evening, and it has really inspired us to move forward. So we'll catch up and sort of lay down some plans. Okay. Thank you,
Absolutely.
everybody, for watching.
Thank you very much.
Thank you.
Thank you.